Welcome everyone to the Anne Klibanski lecture series, and this is the first lecture this year. I'm Miriam Bradella. I'm the director of the Center for Faculty Development, and I'm very excited to welcome our own Dr. Vibha Singhal and Dr. Aime Franco from Children's Hospital of Philadelphia, who will be talking about reprogramming metabolism perspectives from pediatric thyroid cancer and bariatric surgery. So before we begin the formal presentation, there are a few announcements I would like to make about the Anne Klibanski Visiting Scholar Award. So in the beginning of the COVID-19 pandemic in 2020, we noticed that the pandemic unfortunately affected women because of added childcare and household responsibility or the care of ailing relatives. And even before COVID, women were less likely to be visiting professors because of challenges related to travel. And then we took the silver lining of the COVID-19 related travel ban that now many grand rounds and visiting professorships are conducted virtually. And we identified since 2020, 99 women in faculty, clinicians, educators, researchers, or postdocs at MGH who had exceptional promise as leaders in their field and who we thought would benefit from a national or international speaking opportunity, mentoring, and networking opportunities. So the Anne Klibanski Visiting Scholar Award includes being a virtual visiting professor to give a lecture at a national or international institution organized by the Center for Faculty Development. And then the scholars also receive mentoring, professional coaching, and leadership training. Next slide, please. And award is named after our CEO of Mass General Brigham, who was the former director of the Center for Faculty Development, my predecessor, and head of the neuroendocrine unit, and had leadership roles at Harvard Catalyst, the Endocrine Society, and NIH. She herself is a very successful NIH-funded researcher and a strong supporter and advocate for women. She established the Claflin Awards for women faculty and the MGH Backup Childcare Center. Next slide. These are all our scholars. This is the first cohort from 2020. Next slide. That's the next one from 21, 22. And this is the last one from last year. Next slide, click. And these are the champions. These are the people who serve on the review committee and who are real sponsors because they are the ones who pick up the phone and send the email and make the connections for our scholars. So a big, big, big thank you to all of you who are on this picture, because without you, this program would not be possible. Next slide. And we then created the Anne Klibanski Visiting Lecture Series to support and advance the careers of as many women as possible at MGH, but also the US and abroad, because this lecture offers women faculty from the outside institution that hosted one of our Klibanski scholars to present on their expertise, either alone or in tandem as today with our MGH scholar. And these lectures are open to both the MGH community and that of the host institution. And we really hope that this fosters collaborations across institutions. Next slide, please. And here are just some of the institutions where our scholars have given lectures. And if you could click, Brenda, and here we have Children's Hospital of Philadelphia, with our current speaker today. Okay, so now it's my great, great pleasure to introduce the speakers. So first, we will have Dr. Aime Franco, who is an assistant professor and investigator with the Center for Childhood Cancer Research at the Children's Hospital of Philadelphia. She's director of the Pediatric Thyroid Cancer Translational Research Laboratory. She's very passionate about advocacy, both for research and improved patient care and quality of life. Next slide, please. And then we have our own Vibha Singhal, who is an assistant professor of pediatrics at Harvard Medical School and has been the director of the Pediatric program at the Massachusetts General Hospital Weight Center for the past 5 years. She's board certified in obesity medicine and pediatric endocrinology, and her passion involves improving outcomes of obesity management via personalized obesity treatments. So without further ado, Aime, please take it away. And we will have both lectures first, and then we will have time for questions at the end.
Thank you so much for this invitation. It's really great pleasure and honor for me to be here and share with you some of the work that we have ongoing in the lab and the work that we're doing with the Thyroid Center here at CHOP. The learning objectives, and we kind of just talked about it, but I'm going to talk a little bit about the common mutations associated with pediatric thyroid cancer, the adaptations that occur after thyroid cancer therapy, some of the pediatric disease cancer, or pediatric thyroid cancer as a lifespan disease, and then opportunities to more precisely define pediatric thyroid cancer as precision treatment and diagnosis moving forward. So I do not have any financial disclosures, but I do think it's important to disclose the lens in which I view these problems, and the way that I'll be presenting and talking about some of these topics is that I am a PhD scientist, so I do research in the lab and work very closely with our clinical counterparts, but I am not actively treating patients. And I think it's also important to disclose that I am a thyroid cancer survivor. I was diagnosed during my early adulthood at the age of 23. So very much view this disease through the lens as both a researcher as well as a patient and survivor, and how we can think about and strategize collaboratively improving the long-term lifespan and outcomes for thyroid cancer survivors. So why are we even interested in thyroid cancer? And, you know, especially in the pediatric setting. And I think it's really important to note that in about 2006, 2005, 6, we started to see this inflection point and incidence increasing in the pediatric thyroid cancer space. This coincided with the time that the ATA, the American Thyroid Association guidelines came out, and this was in the adult guidelines, but for the first time, they specifically mentioned pediatric nodules. So it was thought that, similar to what we see in the adult setting, that maybe this rapid rise and increase in incidence was due to, I hate this word, overdiagnosis, but seeing these microcarcinomas and really kind of our increased awareness of this condition and finding these incidental microcarcinomas. But interestingly, very different than what we see in the adult setting, is that we saw that with this inflection and an increase in pediatric thyroid cancer cases, we were seeing an increase in the incidence of these microcarcinomas, these small tumors from 0.1 to 2 centimeters. But equally, we saw this drastic rise in the increase of 2 centimeters nodules or tumors and malignancies. So this really was evidence that thyroid cancer is on the rise in the pediatric patient population. Why? We're still trying to understand this. So this is still a rare malignancy in children, but this drastic increase in the diagnosis and findings of these malignancies in children really is troubling. So incidences are rising, but mortality really isn't. So we still are very successful in treating thyroid cancer patients and preventing death from thyroid cancer. However, why should we care? And I would argue the reason we need to care is the standard of care for thyroid cancer patients is removal of the thyroid gland, this nice little endocrine gland in your neck, but the thyroid gland produces thyroid hormone, which really is the backbone for almost everything that the body does. You know, this hormone crosstalks with everything, regulating metabolism, regulating our basal metabolic rate, but also crosstalks and works systematically and collaboratively with many hormones throughout the human body and regulating the nervous system, reproduction, heart, cardiac function, musculoskeletal development. And this is extremely critical both in neonatal development, but during early childhood. And then we also know as really central to kind of creating that homeostasis and acting as a rheostat later in life, and really just regulating the basal function of many of these systems. So when we remove the thyroid gland and we subject our patients to lifelong therapy and thyroid hormone replacement, we really need to be cognizant of what are these off-target effects of supplementing with a synthetic hormone, and really does this replicate and can recapitulate what would happen in the natural setting with the production and secretion of thyroid hormone from the thyroid gland on demand. And I would argue from my lens as the patient that, you know, too often in cancer research, we dichotomize life and death. And we really think that these are the only two outcomes in the treatment of cancer. And we do everything we can to prevent death. But I think along the way, when we look at those are, you know, the only outcome for cancer, is that we forget about what happens in between, and that life really is about the roller coaster in between birth and death. You know, many of us want to prevent death and prolong it as long as possible, but it really is that journey and that roller coaster in between that gives us everything that we want about life and where those memories are made. And I think we need to start thinking about cancer research and the way that we treat our patients through this lens and through this perspective. And the reality is this thyroid cancer can often be cured, and we see a very low mortality, but there is a very high morbidity that's associated with this disease. And what can we do to help remediate some of that morbidity along the way? So I don't want to spend a lot of time going back, but bringing this to the central theme of metabolism and thyroid cancer and really the long-term consequences, that thyroid hormone is very, under normal physiologic conditions, tightly regulated through the hypothalamic pituitary axis. So that, the hypothalamus secretes TRH, or thyrotropin releasing hormone, to act upon the pituitary, and then the pituitary in turn will stimulate the release of TSH. And TSH has two effects upon the thyroid, both the stimulation and secretion of hormone production, so primarily in the form of T4, but also some T3. But it also is a potent mitogenic stimulus for the thyroid gland and really stimulates the thyroid to grow. So under normal conditions and in this intact axis, the thyroid hormone levels, TSH, TRH, are very tightly regulated through positive and negative feedback. And this just is a higher magnification to show that the thyroid follicular cells are really the cells that are critical for the production of thyroid hormone. There are other cell types within the thyroid gland, notably the C cells that give rise to the secretion of calcitonin. And this is just your representative H&E, but in the normal setting, the thyroid follicular cells are organized in these nice acinar type follicles, and thyroid hormone is produced and released and stored in these thyroid follicles. And then upon stimulation with TSH being released from the pituitary, can rapidly mobilize thyroid hormone for circulation and to go to all parts of the body, as well as back to the brain to downregulate the stimulation. So within the thyroid follicular cells are really the most common cells that give rise to malignancy. This is what is the primary focus of my own laboratory and what I'll focus on today in the talk. But the parafollicular cells, or these C cells, can also give rise to malignancy, primarily medullary thyroid cancer. Again, the standard of care, regardless, will be removal of the thyroid gland. So any of the side effects that I talk about in these metabolic differences that occur really result from whether a patient has medullary or follicular thyroid cancers, or follicular cell-derived thyroid cancers. So within those malignancies that arise from the thyroid follicular cell, we see differentiated and undifferentiated tumors. In the context of the pediatric setting, the vast majority are these differentiated tumors. And by far the most common differentiated thyroid cancer are papillary thyroid cancers, or PTCs. A very small subset are the follicular thyroid cancers, or FTCs, but of note, they still all derive from these same hormone producing cells, the thyroid follicular cells. These names really are just more based on how they look in a pathologic features. The papillary thyroid cancers have all of these papillae. Much more rare, especially in the context of the pediatric setting, are these poorly differentiated and anaplastic. And indeed, I've never seen an anaplastic thyroid cancer, or true anaplastic, diagnosed in the pediatric setting. Most of these are in adulthood or even in the geriatric setting, although there is some debate on how that may be changing. But we do know a lot about the genetics of these thyroid cancers. And I would say about 5 to 7 years ago, we actually thought that the genetics were different between pediatric and adult thyroid cancers. We are learning now, and the data I'm going to show you is that they really share many of the same driver mutations and activating pathways. But as I'd introduced before, the TSH receptor is a key mitogenic signal in the thyroid gland, and this can be activated in thyroid cancer, leading to the robust outgrowth of thyroid cells. But by far the most common driver of thyroid cancer across the spectrum of the well-differentiated as well as the poorly differentiated, and in both the pediatric and adult setting are activations of the MAP kinase pathway. And this can occur further upstream with the receptor tyrosine kinases on the cell membrane, all the way down to the signaling molecules RAS, RAF, and also include fusion oncogenes but the net result is activation of this MAP kinase pathway and robust mitogenic signals that lead to outgrowth or overgrowth of the thyroid cells themselves. We also see that there can be activations of the PI3 kinase pathway, either through activation of AKT or some of the other components, or even inactivation of PTEN. In the context of today, we don't have time to go into all of the molecular and genetic biology, but you can see there are many factors and many places in which this pathway can be disrupted. But what also poses, I think, a very unique opportunity is that we do have drugs and targeted therapies for many of these pathways and many places within these pathways. So it opens up a lot of opportunities for us to more precisely utilize therapies for thyroid cancer. And maybe we don't always need to use the blunt force surgical approach of removal of the entire thyroid. Maybe there are ways that we should be thinking about preserving part of the thyroid and using more molecularly based targeted therapies to specifically inhibit the cancer cells while preserving the normal cells. So going in, as I said, we know a little bit about the genomics of thyroid cancer. We know MAP kinase pathway activation is extremely important in this. But up until a couple of years ago, we really thought that maybe there were different drivers in the pediatric setting compared to the adult setting. We know that pediatric tumors tend to present larger than adult tumors. There's more widespread metastasis that's observed in the pediatric setting. So it really was hypothesized that it was a different disease in the pediatric setting and driven by different genetic drivers. So we undertook a pretty comprehensive endeavor to look at both the genetic alterations that were occurring, both through looking at the DNA changes and point mutations, but then also looking at RNA and trying to look at the detection of fusion oncogenes. This was done in 66 patients. The study I'm going to show you is summarized, but we've now done this in over 200 patients. We also took the approach of using some of the commercially available platforms to look in a more targeted fashion for the mutations that were most common in the adult setting. And I know that this is a busy slide, but really what I wanted to draw your attention to are these two boxes. There's a lot of data, and during question and answer, we can go back and look at this and talk about it more. But what was really striking to us is when we looked at the prevalence of the mutations, indeed, we found the same players were playing a role in the pediatric setting that what we had seen in adult patients, that we saw a large number of fusions that occurred both with RET as well as with NTRK. A tremendous number, and about 20 to 30% of these patients harbored BRAF V600E mutations, again, the same mutation that we see in the adult setting. And then we also saw some of these RAS mutations. But what was interesting to us was the prevalence of the fusions. There were many more fusions that we found in the pediatric setting than what we had found in the adult patients. And very interesting to us is that it seemed that the presence of these fusion oncogenes conferred a greater risk to both invasion as well as a lack of remission, whereby in the adult setting, it really seemed that the BRAF mutation harbors the most significant risk. This is the same data, just showing it in a little bit different form in a table, but as you can see, the extrathyroidal extension, that's what ETE is, as well as invasion, was highest in those patients that harbored fusion oncogenes compared to the BRAF or the RAS patients that harbored mutations in these components. We also found that remission was least likely in the patients that had harbored the fusion oncogenes. And when we also looked at the spread to metastatic lymph nodes, both the lateral as well as the medial spread, that the spread was more significant in patients, again, harboring these fusions. And this data, this again, this summarizes it, but what I wanted to bring your attention to is that Again, in the pediatric setting, it was these RET and NTRK fusions that really conferred the greatest risk for distal spread to the lymph nodes and this lack of metastasis, whereby in the adult setting, it really is the BRAF mutations that confer the greatest risk. And another thing, so, our data did support that indeed the pediatric tumors confer or have the exact same mutations that we see in the adult setting. And I will disclose that about 8 years ago, I submitted a grant trying to look at pediatric versus adult onset and utilizing our BRAF model. And I was immediately rejected and told that BRAF was an irrelevant mutation in the pediatric setting. In fact, we do know that it is very much a relevant mutation, but it isn't as prevalent, as you can see in this light gray bar, compared to the adult setting. And it's interesting that we see kind of this flip-flop of BRAF as the most prevalent mutation in the adult setting, followed by the fusions, whereas in the pediatric setting, it really is these fusions that are the most common genetic alteration. We still don't understand what's driving this, and that's something that we're very actively investigating. But you can see even when we stratify the pediatric patients and look at the median age of their diagnosis, those that harbor the NTRK or the RET fusions tend to be the youngest patients. So clearly age is driving, in our opinion, driving some of this phenotype, but it really is going to take additional studies and work to understand whether this is something inherent to the thyroid cell themselves, or maybe some of the tumor microenvironment and the age of the patient at their the time of diagnosis. This data, we took another approach, and I know this is the summary of a lot of data, but what I wanted to show is we've also started to look at the microRNA profile of these tumors, and that this may also represent some novel therapeutic strategies. And similar, what the purpose of this study is, we used a microRNA commercial panel, and it's dichotomized looking at the microRNA expression patterns within thyroid nodules to understand whether they're at greater risk to be benign or malignant. And they've dichotomized this score to either say positive or negative. And indeed, we found that similar to the adult nodules, those that were malignant most often were positive for this microRNA signature. But what was really interesting to us, and is really the focus of some of our ongoing work, is that these signatures, even though they were dichotomized to be positive or negative, there are numbers that are associated with this. And we found that the numbers associated and the level of activity of this pathway is very different in the pediatric patients versus in the adult. Again, suggesting that there's something very different about a pediatric thyroid and a thyroid from a young patient than from the adult fully differentiated thyroid gland. So why is this relevant, and kind of bringing it back to, some of the long-term implications? As I said, thyroid hormone is very tightly regulated in the normal setting and through the hypothalamic pituitary axis. And it very much is a dynamic regulation. In the case of thyroid cancer, we most often remove the thyroid gland, and we really eliminate a very essential part of this metabolic and regulatory pathway, whereby we give a single bolus dose of thyroid hormone to our patients for the rest of their life in the form of a pill. And we really haven't spent a lot of time, and this is one of the limitations, in my opinion, in our field, is really understanding the significant consequences of this lifelong thyroid hormone supplementation. And we need a lot more work to understand really what does this bolus dose mean versus the dynamic regulation that would take place in the homeostatic state when this entire axis is completely in play before patients undergo thyroidectomy. So really, to summarize, and I hope that, in this brief time together, I've been able to show you that the pediatric thyroid tumors with fusion drivers are more invasive than the BRAF or RAS-driven tumors. This is unique to the pediatric setting, whereby the BRAF mutations are more prevalent and tend to be more invasive in the adult setting. That by knowing some of these genetic drivers before surgery, it may be useful in determining the extent of surgery. We didn't talk about this, but because we know that the more invasive disease is associated with these fusion drivers, it could become a mechanism and a way for us to stratify patients that may have the best benefit from a lymph node dissection if we knew this information up front in the pediatric setting. That pediatric thyroid tumors do harbor clinically actionable genetic mutations. And I think this really opens the door for molecularly targeted therapies and for a way to us to think about maybe being less aggressive in the therapeutic. Can we preserve half of the thyroid gland and really maintain at least part of that hypothalamic pituitary axis and really maintain some of this homeostatic regulation of the thyroid. And that standard of care is complete thyroidectomy, which results in the lifelong thyroid hormone supplementation and disruption of the natural ATP axis for our patients. And I hope that we can start to maybe shift the lens of how we look at pediatric thyroid cancer as not just, again, a dichotomy of not dying, but really that this is a lifespan disease that these patients will be dealing with for the rest of their life, and that we really need to start thinking about quality of life and how these patients will survive long term. I want to end with this, though, is I think, as we become very adept at understanding the genotypes of our therapies and that we can do many more molecular and genetic tests, these are all extremely expensive tests. And how do we make sure that this is all accessible to all of our patients? And I think we really need to very seriously consider and think about how we treat our patients and how we are doing research through an equity lens to making sure that all of these new therapies, these new diagnostic tools, and these advances that we continue to make every day in the laboratory really are going to be inclusive to all communities and further are going to be accessible to all of our patients moving forward into the future. So the lab, this wouldn't be possible with the work from my wonderful lab that does all of the work behind the scenes for me, the funding, the clinical collaborators and my team here at CHOP that we really integrate so closely within the Thyroid Center. And of course, the patients that have been willing to donate tissue and be a part of this research spectrum with us. So I'm going to stop sharing and turn it over to Vibha, and we'll take questions at the end.
Thank you so much, Amy. This was so powerful and so fantastic, also given your personal story. So thank you so much. We will wait, as you said, for questions after we're done. So Vibha, please take it away.
Thank you so much, Miriam. And thank you, Amy, for a really wonderful talk and inspiring. So So first and foremost, I would like to thank the Center of Faculty Development for giving this opportunity to present sort of my clinical work and the research that we are doing. I would, when we're in this journey in the young career and standing on the shoulders of giants, and Dr. Klibanski was one of my first mentors when I stepped into research during my fellowship years. And I still remember a remark that she made when I was like, am I suited for a research career? And she said, you will gravitate towards what you're passionate about, and you better love what you do because you're sacrificing a lot to do that. So those words still resonate, I would say, once a week, and ground me and bring me back. And of course, next is Dr. Misra, who is always there for me, has been an amazing inspiration. She always says there's no substitute for hard work, and she herself is a role model for that. But is very patient and has stuck with me through thick and thin, and will tell me, take your time, you're almost there. So thank you. And finally, last but not the least, Dr. Bradella, who has been my mentor, collaborator, guide. And I still remember, Miriam, you telling me you will find time for things you prioritize the most. So, so thank you for this opportunity and being there and being the guide. And I think this program was so helpful. It almost towards the end of the year, but just the collaborations and friendships that I have built through this journey. With that, these are my disclosures, really nothing relevant to the talk here. Through the next few minutes, I will briefly discuss the rationale for considering the metabolic and bariatric surgery in adolescents with severe obesity, and then discussing the weight loss and metabolic outcomes after surgery. I see many familiar names in the audience, so thank you for coming. I apologize if some of the talk you've already heard, but hopefully we could still learn something new. So let's meet this young lady, Zizi. She is a very inspiring patient of mine. She is 14 years old, young woman, and I present the pictures with her permission, which will hide before we upload it to the public. Young lady with autism with class 3 obesity. When she presented, she was postmenarchal. She had irregular menses, very limited language. She came in singing beach, I want to go to the beach. Her BMI put her in the class 3 category, and her labs were significant for an A1C in the very early pre-diabetes stage and normal liver function test. She also had PCOS and pre-diabetes, as I mentioned. So we got her assessment. So as you know, I work with the Weight Center team, where we have access to a wonderful team of psychologists, nutritionists. She was assessed by everyone. Did not find anything glaring. Actually, mom was very much on top of her dietary needs, but we still kind of gave her the 6-month medical nutrition therapy, meeting with the team, coming back, and they were good with that. So what happened was she had some initial weight gain, but finally she stabilized her weight. We repeated labs after 9 months, and her A1C increased from 5.7 to 6.1%. We did not have any weight loss. So here is a young lady with autism, class 3 obesity, pre-diabetes, PCOS, and psychosocial stress. I distinctly remember her mom telling the story. She's like, which brought almost tears to my eyes, that she's like, you keep telling me take her to the swing. Her, she wants to go to outside and play in the park, but 1, she can't keep up. 2, she doesn't fit in the swing set. She has rashes and marks from the swing. So what do I do? Help. What are our next steps and how did we approach this? I'm going to digress a little bit and go over what is obesity. Is obesity a disease, which it is declared by the American Medical Association, but do we treat it as such? So the definition of disease is an impairment of the normal state of the living animal that interrupts or modifies the performance of vital functions. In the state of obesity, I think it's a disease because there is accumulation of excess body fat to a level that affects health. And you don't have to have hypertension or diabetes to call it disease. It is a disease because it has mechanical consequences, it has psychological consequences, and it is chronic, it is relapsing, it is multifactorial and neurobehavioral. And we don't have a cure yet. We have treatments that help mitigate it, but again, it's a chronic disease, so we have to stay on top of it. Sorry. Very briefly, which many in the audience are totally conversant with this, but we have a classification of the severity of obesity. I think it helps track the disease better and also helps provide some guideline and direction as to the treatment options that should be considered as the severity of the disease increases. I believe adult obesity is a pediatric disease, not just a pediatric disease, or I should flip it the other way. Pediatric obesity is most likely causes adult obesity, which is highlighted in this graph here. On the x-axis, they have the current age of the child. So this was data from a large database study where they used computational models and they had prospective data and predicted the probability of obesity at the age of 35 if based on the weight status at young age. So for example, if you have severe obesity, which is presented by the blue line, at the age of 15, there is almost, trying to get my laser pointer back. So there is almost a 90% chance that there will be obesity in adulthood without any treatment. Furthermore, the disparities are highlighted as early as first year of life based on race and ethnic group, with Hispanic and Black children having a higher rate of obesity prevalence in the first year. So where does my patient come? So Zizi is right here in the severe obesity zone with 90% likelihood, more than 90% likelihood that she's going to have obesity at the age of 35. So pathophysiology of obesity, it follows the thermodynamic law of energy intake and energy expenditure. So we can talk about every calorie is not the same, how you process calories is different, but ultimately it is a balance of intake and expenditure. Now, and most of the regulation sits in the brain. So very important realization in the last few years. However, the appetite and the food intake, so I'm not talking about the expenditure side of things here, just the intake side of things, is very intricately regulated, much like other bodily functions of temperature regulation, as Amy just told us about thyroid hormone regulation. And these are homeostatic pathways, hedonic pathways, and cognitive pathways, and they all interact. However, in the disease state of obesity, all these pathways are altered, and they lead to perpetuation of behaviors which cause positive energy balance. So if there is an individual with obesity, their cognitive control in going for a high-calorie chocolate chip cookie after they've had a good lunch meal will be less than somebody who does not have obesity. So it is not their fault, but it's the pathophysiology of the disease. Body works hard to maintain its weight and energy balance. It strives for constant fat mass. So for example, an average adult needs about 1,300 kilocalories and consumes about 2,000 to 2,500. So if we were to exercise all the excess calories, you almost have to run half a marathon every day, but most of us don't. So to maintain an adult body weight within the 20-pound zone, we have to consume about 1 extra potato chip a day. And if you think, most adults maintain their body weight within the 20-pound window through their adult life. So there is a good regulation of the system. And when we, listen about, oh, I did this and I lost 5 pounds, I lost 10 pounds, I don't know why my patient can not do that. That is because the 10-pound regulation is still within this zone and there is no disease state of obesity. However, when the disease occurs, this regulation is disrupted. Another example is weight loss during acute illness, acute gastroenteritis. We lose 6 pounds, we come back to between 5.9 to 6.2 pounds back. So it is very closely and intricately regulated. However, so there is some fat mass set point. We don't know anatomically where it sits, but based on our genetic predisposition and other factors like processed diet, inadequate physical activity, inadequate sleep, stress, weight increasing medications, antipsychotics, steroids, and life changes, aging, pregnancy, menopause in adults, this fat mass set point is dysregulated. And that is what we try to address when we are trying to address all these factors, is let's see if your fat mass set point can be brought back to the normal zone. But now based on this knowledge that obesity is a disease, Zizi's fault that she struggles, Zizi's not at fault that she struggles with obesity, and her caregivers are taking adequate responsibility to try and modify those healthy lifestyle factors. There is 90% likelihood that she will have obesity at the age of 35 without treatment. She already has some complications from obesity and is at high risk for others, including type 2 diabetes. She has an altered fat mass set point and needs treatment appropriate for class 3 obesity. So we went on to the stepwise approach to management of obesity, which would be true for management of any chronic disease, like juvenile arthritis, like severe hypertension. As the potency of the treatment increases, so will the risk and the cost. As the severity of obesity is more, we need to use a treatment that is more potent and potentially more risky and costly. So we recommended surgery or discussed surgery with Zizi and her family, and they were in for it. So let's review some of the data we have that we use in the discussion of this treatment option with the family. The most common types of surgeries currently done across the nation and pretty much worldwide are vertical sleeve gastrectomy, where you make stomach into a sleeve, take much of the gastric antrum out where the hunger hormone ghrelin is made. So, and with many other changes in hormones and neuronal feedback, there is decrease in appetite and decreased caloric intake to cause weight loss. And the other procedure is Roux-en-Y gastric bypass, which is being done less often now, where the stomach is reduced to a small pouch and is connected distally to the intestine. There are very strict indications for surgery, which would be class 2 obesity in the presence of a complication, or class 3 obesity. The absolute contraindications are pregnancy or breastfeeding, unresolved substance abuse, untreated psychiatric disorder, or suicidal attempt in the last year. What about the role of race and sex on adolescent metabolic bariatric surgery? So this is a retrospective analysis of almost 1,500 adolescents. They found that males had higher preoperative BMI and higher rates of complications, and Blacks had a higher preoperative BMI and higher rates of hypertension, OSA, and asthma, suggesting that males and people with Black race are not getting the procedure early enough when they are eligible to get it or when they need it. However, the weight loss and the complication remission rates did not differ by sex or race. Just to look at the bariatric surgery utilization, the graph here shows the racial distribution with the top panel showing the expected rate based on the rates of severe obesity and in the population, with blue being representative for whites, red for Blacks, and green for Hispanics. And the lower panel is what is actually prevalent. And we can see that white adolescents undergo bariatric surgery at almost 2 times the rate than Blacks and Hispanics. Much of our data with regard to the bariatric surgery outcomes come from the Teen Lab study, which was a consortium of 6 hospitals funded by the NIH. And their demographic was mean age of around 17 years. They did have, the timing of this study was such that 2/3 of their population had Roux-en-Y gastric bypass and 1/3 have sleeve gastrectomy. 75% were females, which is the prevalence or the demographic that we see in terms of bariatric surgeries. It is female predominant. They had predominantly whites in their participants, and a quarter of them were Blacks, and majority were in the low socioeconomics with regard to the income. At 3 years, when we look at the weight loss outcome with the red dashed line showing the sleeve gastrectomy group and the blue line showing the bypass, we can see that the nadir of, which is about 30% change in the BMI from the starting. So loss of 30%. So just to put in perspective, if you take in terms of weight, somebody who's 200 pounds, losing about 60 pounds, was achieved at the age or after 1 year post-surgery. And this was maintained with a slight rebound at 3 years. So at 3 years, about a quarter of the participants no longer had obesity, 75% still did. And that is because their starting BMI was a median of about 51. So if we start higher, we will end up higher. There is only so much delta that the surgery can achieve. This is another study which is limited to the Roux-en-Y gastric bypass group. It is a prospective analysis in adolescent cohort. They had a very good high level of retention of about 80%, which is hard to see in this population. And the data are 5 to 12 years out with a median follow-up of about 8 years. And we can see in the top graph here with BMI, this is the BMI at different points. So the starting BMI was close to 60 in adolescents. The nadir mean BMI for the group was around 35, and they maintained it to around, they got to around 41 at 8 years post-surgery. Something to keep in mind if we take account at 8 years is the fanning of the curves for individual participants. And while there are people who rebounded quite a bit, many are in this zone, so maintaining their weight, and there's some who are even lower. And this is the nature of obesity as a heterogeneous disease and a heterogeneous response to the same treatment. The bottom panel is showing that the long-term BMI and the BMI at baseline is, and as I was just alluding, the ultimate or the long-term BMI was totally dependent on the initial BMI. This is the outcomes from our center. We are fortunate to have a center where same surgeons, same kind of program is provided to both adults and adolescents. So it was an opportunity to almost head-to-head compare the outcomes in adolescents and adults. So it was about 150 subjects across the age group having both kinds of surgery. And we had outcomes up till 4 years. And we can see in the panel on the right with adults in the gray line and the black being represented by adolescents, that adolescents almost had higher, and this was statistically significant, higher weight loss as compared to adults. And there may be something about early intervention in the treatment of severe obesity that led to better outcomes in adolescents. This also translated in terms of resolution of complications. So when we looked at proportion of individuals who resolved their complication of hypertension, of diabetes, adolescents in the black bars had greater resolution as compared to adults. Again, suggesting that shorter duration of disease may have better resolution outcomes. This was also replicated by the teen labs and their corresponding adult labs cohort. This is exclusively in RYGB. However, our data had both RYGB and sleeve gastrectomy. And they found similarly that type 2 diabetes and hypertension resolved better in adolescents as compared to adults. However, these differences were not seen in the hypertriglyceridemia and HDL resolution. So also thinking about, the weight loss outcomes and the kind of surgery I'm going to discuss with Zizi. She's African-American, and does it matter? So this was a study which was a comparative effectiveness study of more than 36,000 patients. This included both adults and adolescents. Again, mainly highly female patients representation. They had Blacks, Hispanics, whites in their cohort, and the panels A, B, and C represent Black individuals, Hispanic individuals, and white individuals, with orange lines representing sleeve gastrectomy and the green one as bypass. And we see that all the groups achieved about 30% nadir weight loss with no difference across races. Similar were the results for the cardiovascular outcomes at 3 years from the cohort, Teen Labs cohort. There was normalization of dyslipidemia, elevated blood pressure, higher inflammation markers, and older participants at the time of surgery were less likely to resolve dyslipidemia than younger. For the sake of time, I'm going to speed a little. This is the resolution of NAFLD after bariatric surgery, and I like this study because this used liver biopsies, which is the gold standard for the diagnosis of NAFLD. And we can see in this, where I would like you to focus your attention in this elliptical here, is when there was fibrosis, the white panel is representing the non-surgical weight loss group. The gray panel is the gastric intragastric balloon device, and the black panel is the sleeve gastrectomy group. And we can see that at T0, the sleeve gastrectomy group had the highest rate of fibrosis. And after at T1, which is 1 year after treatment, there was significant resolution of fibrosis in the sleeve gastrectomy group. However, the non-surgical group had increases in fibrosis. Lastly, with regard to PCOS, which Zizi had, this is a meta-analysis of 14 studies, including both sleeve gastrectomy and bypass. A pretty rigorous meta-analysis for what they come with regard to this area of investigation. They found that with regard to menstrual abnormalities in the PCOS girls, there was resolution from 82% to 15% after surgery. Similar decreases in hirsutism, and the total testosterone also decreased by 26 nanograms per deciliter was their estimate. So, and this study included adult women, and they reported that 31 out of 32 women were able to get pregnant after metabolic surgery. The surgical outcomes also translate to next generation. And in this study, there is dyads of children born after bariatric surgery who demonstrated lower rates of obesity and cardiometabolic risk as compared to their siblings who were born before metabolic surgery. And when they looked at their DNA methylation, they found that almost 5,500 genes were differentially methylated between the two sibling cohorts of before and after metabolic surgery. And they were primarily in the glucoregulatory, inflammatory, and the vascular disease genes. So mothers having bariatric surgery had impacts on their siblings, which we now know and accept. Finally, very briefly about the complication rates when we compare adolescents and adults, there was a higher rate of cholecystectomies and higher rate of surgery, slightly higher rate of surgery in adolescents. And this was, when we read through the fine print of the paper, it was just one participant who unfortunately needed 3 more surgeries. But everybody other, if you take that participant out, the complication rates were similar. To just take our attention to the 3 deaths that are reported in these data, 1 was from a sepsis in a patient with type 1 diabetes, and 2 were from overdose. So the implications on mental health after bariatric surgery is a very active area of investigation at this point. And the current recommendation is good follow-up post-surgery. So clearly there are lots of ups from the surgery that we have discussed, but there are still some data that need to come in terms of durability, lifelong need of vitamins, and I've not presented the bone effects on the bone from the bariatric surgery. Nonetheless, it is a proven effective treatment for severe obesity and should be considered when needed. And the referral for children with severe obesity to a center with advanced treatments and support is hopefully more accessible with our current AAP guidelines also being released, which advocate this mode of treatment for severe obesity. So this is Zizi after her surgery. This is her weight loss graph. She went from a weight of 308 pounds to 218 and celebrated her sweet 16 in a beautiful dress. With that, I would like to take the opportunity to thank everyone for supporting and encouraging throughout, and happy to take any questions.
Wow, Vibha, thank you so much. This was fantastic, very thought-provoking. Obesity is such a complex disease. So we have, unfortunately, only 3 more minutes, but if there are any questions, please unmute yourself or raise your virtual hand or put it in the chat. Saray, very nice to see you from Newton Wellesley.
Yeah. No, it's nice. Great lectures. I really enjoyed both of them.
Yeah.
Amy, I have a question for you in terms of, these NTRK mutations, and you mentioned like changing the surgical intervention, possibly to adding node dissection, which a lot of us do sort of already empirically for young people anyway. But what about neoadjuvant treatment? Is there any thought around that, especially in these sort of locally invasive disease?
So yes, we've been thinking about that in all aspects of it. Is how do we guide the surgical? Do we do it as neoadjuvant? And also now looking at it and thinking of it in the context of metastatic disease and distant metastatic disease, primarily to the lungs. And, we have a lot of ongoing work to think about how are these drugs cytostatic and cytotoxic, but then also how some of these molecularly targeted therapies may also redifferentiate the disease and open up windows for radioactive iodine therapy. And there's 2 prongs to that, is whether they redifferentiate to increase just the uptake of iodine, which is necessary, or do they also have some role in increasing radiosensitivity, so making the therapies in and of itself more efficacious, as well as increasing the uptake. So these are all a lot of ongoing and investigations in the lab, and then understanding, is it the same in pediatric as it is in adult? And are those redifferentiation programs going to look the same in the pediatric population as they do in the adult? And I personally think the answer is no. And I think we have a lot to learn about what these differentiation programs look like in the pediatric patient to begin with. When are we terminally differentiated and an adult thyroid? And that answer, I just don't think we know on a molecular genetic level. And what does a real, true, normal thyroid look like to begin with?
I'll just put a plug in for Amy. Amy is like the real deal. She is amazing, amazing scientist, amazing person, amazing, endocrinologist. I mean, just amazing.
Thank you.
Thank you. Thanks, Sarah. Anna Abrams, nice to see you.
Oh, hi. These were wonderful talks, and actually I have questions that overlap for both of you. So I'm a child psychiatrist in the pediatric oncology group. We don't see a lot of thyroid cancer because our thyroid cancer patients are treated in the adult world. But we have a lot of kids with brain tumors who have hypothalamic obesity. And I'm really curious because we have a lot of challenges in treating this afterwards. As to whether or not gastric bypass surgery for them works, because my experience has been they have the surgery and then their weight goes up afterwards because the metabolism hasn't changed. So I have some patients who are on Ozempic, I have patients who are on topiramate, on stimulants. So I'm curious, thinking about it from the cancer perspective and the obesity perspective, how you think about these patients.
I can take first, Amy, and then challenging, very challenging, right? Hypothalamic obesity. And I think there are a lot of treatments in the work. Some of them are more targeted. Hypothalamus is sitting right up there, very high in the control. So I know there are studies going on with setmelanotide, which is MC4R agonist. So bypassing that stimulation that needs to, or the feedback that needs to come from the hypothalamus. So fingers crossed for that. There is oxytocin trials that are going on in hypothalamic setting. So, which is slightly different mechanism than the typical leptin feedback pathway that the hypothalamus typically regulates. What we have right now is what you're using is, trying a cocktail. I managed 2 or 3, but this group is the toughest in terms of weight loss, getting weight loss. We've had better success even with Prader-Willi than with hypothalamic obesity in that setting. So so everything that we can do and approach from that perspective. Amy?
Well, I was just saying, I think that I don't have an answer from the cancer perspective, but I think it really just highlights the need for these transdisciplinary teams of addressing that, so often we dichotomize cancer, life, death, prevent death at all costs. And we really don't think about how interconnected all of the different systems are. And we think about preserving life through eliminating the tumor and getting rid of that. But, tumors are dysfunctional organs in and of themselves. And oftentimes, can't remove the entire brain, right? But we're disrupting the homeostasis and the physiologic function of that entire organ. In thyroid, we have the option of removing the whole gland, but we don't think about what those consequences are and those interconnections across multiple systems. And I think this is why it's just so critical to have all of these voices at the table. And I love having this seminar to bring all of these different perspectives together, because we don't often get the opportunity to do that. One of the things that we do at CHOP and in the thyroid centers, we have a tumor board. And I know lots of other places, but what I love about our tumor board is we actually bring in the lab, and I'm there and I bring in our lab members, because I think it's important for them to hear all the clinical challenges and all of the different components, because they don't see that working with cells in a dish, or even at times working with just the animal models that can't talk to us about the other things that are going on. And I think it's really critical, because I think all of those different perspectives are going to give us more innovative strategies on how do we solve or address these problems moving forward.
Great. What a great closing. There was one question, I'm just going to ask that. That's the last one. Vibha, Paul Copeland, do you see any clinical characteristics that would lead to a medical or medication approach, GLP-1, RI versus surgery?
It's, I think, just more so the severity of obesity and complications. And then finally, it gets to the tolerance of medications. Now with newer GLP-1 analogs and dual agonists, the weight loss is better, but they're still hard to get approved by insurance in our pediatric age group. So, response to treatment, family preference, no specific patient characteristics per se.
Great. Thank you. We are after the hour. This was a fantastic session. So really, I agree, Amy, like having both Vibha and you together talking about things that maybe at first sight are not really connected, but actually are. So thank you so much for giving this excellent presentation. Thank you to the audience and for your great questions and for being here. You have a great day.
Thank you, everyone.
Bye.